Alright, welcome back. This is the second video about cranial nerves, and this time we're going to be talking about cranial nerve 7, the facial nerve. Now the first video we talked about the trigeminal nerve, which is largely sensory to the face and motor to the muscles that move the jaw, the muscles of mastication. The facial nerve has similar things going on, but it's laid out a little bit differently. Its major function clinically is motor to the muscles of facial expression and a little bit of sensory to just a portion of the ear canal. So right here we've got our thalamus, midbrain, pons, medulla, and down here would be the spinal cord. And we're going to draw in the first nucleus that we're really concerned about right here near the pontomedular juncture. This is the motor nucleus that's going to supply those facial muscles. And happily for us, that is called facial motor nucleus. Now these muscles are derived from the pharyngeal arches, therefore they're branchiomotor or special visceral efferent. So we're coloring them in this way. As these guys exit, they go through and exit around the pontomedular juncture and enter the temporal bone at the internal acoustic meatus. And the other thing exiting there is going to be cranial nerve 8. So you can actually have any problems here cause facial motor loss as well as difficulty hearing and vertigo due to loss of the inner ear innervation. It's the internal acoustic, sometimes called the internal auditory meatus. Once it's inside the temporal bone, facial nerve takes a fairly straight course and takes a sharp bend. And it travels through the middle ear before exiting the stylomastoid foramen. So let's draw in chamber right here. This is the middle ear where all the ossicles, incus malleus, and stapes are at. And it exits after traveling through the facial canal through the stylomastoid foramen. And no big surprise, that foramen is located between the styloid process and the mastoid process of the temporal bone. Now there's a few things going on in here that we're going to revisit. But right now, the main thing I want you to know is that there's a branch that heads posteriorly just around the back of the ear, and that is the posterior auricular branch. A posterior auricular nerve, and it's supplying the muscles around the ear. So if you know somebody who can wiggle their ears, that's it. The other branches, very big branches, exit anteriorly and head forward on the face. And there's 5 main branches that we're going to be talking about here. And before we get to their names, they all travel through the parotid gland. And the parotid gland pretty much wholly encompasses these guys as they exit the stylomastoid foramen. It would normally be sitting right about here, but I've displaced it forward so we can see. And parotid gland cancers or surgical procedures will sometimes traumatize these nerves. And if you do that, you lose innervation to the muscles that are innervated by them. So the ones that are located near the top of the face are the temporal branches. Temporal branch of 7. We go down to the area around the jawline, not the jawline, pardon me, the cheekbones. That's going to be the zygomatic branch of 7. And next up, the buccal branch. Now you may remember the buccal branch of 5 was sensory to the cheek. Buccal branch of 7 is motor to the cheek muscle, buccinator. Next up, around the jaw, we've got the mandibular branch of 7. And lastly, the cervical branch, going to the platysma muscle, which is the one on your neck that kind of stretches out whenever you're straining. So these guys are the major motor to the muscles of the face, and if you have trauma to any one of these, you lose the ability to move the facial muscles in that area. Commonly, you can have impingement or some difficulty here at the stylomastoid foramen, which is going to cause what's referred to as Bell's palsy. And all the muscles on that side are going to droop and be relatively acontractile. Forehead can't wrinkle, jaw or mouth corner can't lift, eyes can't blink easily. That's Bell's palsy. Now I said we're going to come back and mention a couple others. Those guys are, there's a small muscle, well, not really too small, just underneath the jaw. That's going to be the posterior belly of the digastric. We talked about the anterior belly being innervated by cranial nerve V3, the trigeminal branch, specifically the mandibular branch, digastric muscle. And in the ear canal, we've actually got a tiny little branch that goes to a muscle attached to one of the ossicles. Cranial nerve 5 innervated the tensor tympani that attached to the malleus. Cranial nerve 7 has a little branch that goes to the stapes, the bone that actually creates the fluid waves inside the inner ear that allows vibration to be transduced into sound or an electrical impulse. And that's going to be the nerve to stapes, or probably better, we'll just call it, or sorry, nerve to stapedius muscle. So that is really about it for motor branches, special visceral efferents based on 7. But we have a little bit of sensory going on, and I stress a little bit. 7 is sensory to a small branch near the external ear, near the auricle, and that sensory branch we're just going to draw in here in green, going through the middle ear, alongside all these guys, and right here at this bend is where its cell bodies are located. And that's why these collection of cell bodies are referred to as the geniculate ganglion. Genu, or bend, is where any sensory cell bodies associated with cranial nerve 7 are located. And these are, as with 5, pseudo-unipolar, so their axon stretches towards the cell body maintains them, but the axon continues along the rest of the nerve through out to the internal acoustic meatus and gets to the brainstem. And here, since it's sensory, it's going to project to somebody we talked about last time, the spinal trigeminal nucleus. So these fibers stretch down, they synapse with fibers inside here, which then decussate and head to the thalamus as part of the trigeminal thalamic tract. Now that's it for the major functions of the facial nerve that you're going to see and have people complain about easily. The special visceral efferents, motor, and the sensory, no one's really going to complain too much about their ear having a tiny little patch of numbness, but that's not all that's going on with the facial nerve. The other things are parasympathetics. Facial nerve has fibers that come from another nucleus up here in the pons, and these are parasympathetics, or general visceral efferents, meaning they're making organs and smooth muscle move or causing glands to secrete. And these branches exit along with the rest of the facial nerve, travel through the internal acoustic meatus as part of it, and right here at the geniculate ganglion, one branch peels off. Another branch continues through the middle ear and then decides to leave the facial nerve altogether and course on its own through the temporal bone. And if you've been paying attention from the last video, you may remember these guys have a name. The first one is the greater petrosal, and it's going to travel through the temporal bone, through the pterygoid canal, join up with the deep pterygoid, or the deep petrosal nerve, form the nerve of the petrosal canal, and it's eventually going to meet up with cell bodies hanging out in the pterygopalatine ganglion. For details of this branching, go check the last video on the trigeminal nerve. And then those fibers are going to follow branches of the maxillary nerve, V2, and a little bit of V1 to get to the lacrimal gland, and the mucosa of the palate, nasal area, and maxillary sinus. So when you're asked about tear formation, you want to think that the parasympathetics have their first cell bodies in this guy, who I forgot to label, the superior salivatory nucleus. Then they pass through as part of the facial nerve, internal acoustic meatus, at the geniculate ganglion where it bends. They jump off as the greater petrosal nerve, synapse at the pterygopalatine ganglion. Then the postsynaptic axons travel along branches of V2 and sometimes V1 to reach their targets. Now the other guy that jumps down through the middle ear and jumps back through the middle ear, actually going in between the incus and the malleus, passes out through the temporal bone at the petrotympanic fissure. And hopefully you remember this guy's called the chorda tympani. Sorry, the angle's a little weird here if my penmanship gets bad. And the chorda tympani joins with the lingual nerve, a branch of the mandibular nerve, V3, follows it until it reaches the submandibular ganglion, and then, again, referring back to the last video, if need be, jumps back on branches of the lingual and gets to its targets underneath the jaw and inside the gum line, the sublingual and submandibular salivary glands. Alright, and that's it for the autonomics associated with 7. And we said the sympathetics are going to jump on here as the deep petrosal nerve. That's covered in another video altogether, the autonomics of the head and neck. Refer to that one if you have any further questions. But the presynaptic cell bodies are always located, associated with 7, are always located in the superior salivatory nucleus, travel with the facial nerve, and then they either jump on greater petrosal to the pterygopalatine, and then postsynaptics to lacrimal gland, mucosa, etc., or they travel through the chorda tympani, through the petrotympanic fissure, to reach the submandibular ganglion, along with the lingual nerve, lingual branch of the mandibular nerve, to reach the sublingual and submandibular glands. We are almost done. And almost comes from the fact that was mentioned in the last one, the last lecture as well, that the anterior 2/3 of the tongue has taste buds on it. And even though the lingual nerve innervates the tongue itself for heat, temperature, proprioception, things of that nature, the taste buds for some reason are innervated by cranial nerve 7. And these taste bud fibers travel with the chorda tympani. Sorry if the pink's getting a little hard to see. I'll try to press it a little more. And these taste fibers travel back along with chorda tympani, rejoin the facial nerve, and taste is a sensory modality. And because it's sensory, it's got sensory cell bodies, and they're located in the geniculate ganglion. That's going to travel back. I'll tell you what, I'm going to cheat here and use red just so you guys can see it. So chorda tympani, back through the middle ear, cell bodies in the geniculate ganglion, and then passing along with the facial nerve and the temporal bone out the internal acoustic meatus and into the brainstem. Now this is something we haven't spent a lot of time talking about yet. Taste is what's referred to as a special visceral afferent, and those project to a series of pretty well characterized nuclei in the brainstem, and the one that taste fibers go to is called the solitary nucleus. So solitary nucleus in the medulla is where these fibers are going to go and synapse, and then they're going to decussate and head up to the VPM thalamic nuclei, just like sensory to the rest of the face, because taste is a form of sensory. Now, one thing about this nucleus that's important, this whole thing in red is called the solitary nucleus. But functionally, it's divided in a pretty important way. The rostral, or the uppermost part, is called the gustatory nucleus. The lower part is called the cardio-respiratory nucleus. And that name should make you think it's relatively important. This is where inputs from the heart and the lungs go to update the central nervous system about what's going on with the organs. So damage here pretty much means you're unable to breathe and have your heart beat automatically anymore. Damage in the upper part of the gustatory nucleus means that your taste fibers are knocked out. Pretty severe discrepancy there. It escalated relatively quickly in terms of importance as it goes down that way. Alright, now I believe that's everything we wanted to cover regarding the facial nerve and its various functions. Before we stop, I just want to run through some lesions, because any lesion of the motor branches here will cause motor loss along that branch. So a portion of the face will be deinnervated and be amobile. A lesion affecting all those motor branches, as well as possibly the sensory branch, will result in Bell's palsy or complete acontractility of that side of the face. Lesions inside the middle ear will cause Bell's palsy plus hyperacusis, or sensitivity to loud noise, because the stapedius muscle, innervated by the facial nerve, keeps the stapes from slamming into the oval window too hard and causing excessive noise to be felt as the fluid wave moves through the cochlea. Now we move further back. Here we're going to lose taste because the chorda tympani is also joined on the anterior 2/3 of the tongue. And if we go right about here, before the geniculate ganglion, and put a lesion in that spot, tearing will be preserved. If the greater petrosal is already left, the ability of the eye to make tears and stay moist will not be impeded, even though taste is gone, motor to the face is gone, and hyperacusis exists. I should also mention there's a little bit of a dry mouth going on because you've lost innervation to your sublingual and submandibular salivary glands. However, if the parotid's intact, somebody may not even notice that, because the parotid, innervated by 9, will be able to create enough saliva to keep the mouth wet. If we lesion somewhere in the temporal bone proximal to the greater petrosal nerve, then we've got Bell's palsy, motor, hyperacusis, motor, lack of taste on the anterior 2/3 of the tongue from the visceral afferents on the chorda tympani, possible dry mouth from loss of the parasympathetics, and loss of sensation in a portion of the ear canal, which I'd be amazed if anyone ever actually came to a doctor complaining about. But one thing that they will complain about is loss of the ability of the lacrimal gland to make tears, because the eye gets dry, gets very irritated and red, and it's very painful. And the same things are seen if we have a lesion inside the cranial cavity, but if it happens just external to the internal acoustic meatus, you've probably also involved cranial nerve 8, and you can add vertigo and possible hearing loss to that list of problems. Alright, there's one last clinical correlation I want to kind of get in on, and that's mostly because of something that confuses people about Bell's palsy. Bell's palsy is defined as a lower motor neuron disease associated with the facial nerves, a complete lack of facial muscle activity on one side. But if you have a central lesion that wipes out the innervation going to the facial motor nucleus from the cortex, so here's the corticonuclear or cortical bulbar tract. If I wipe this guy out, I don't wind up with complete loss. I wind up with my maxillary and mandibular regions deinnervated, but my forehead can still wrinkle. And that's because the axons, we'll draw them in right here, that are specifically going to the temporal branch receive innervation from both sides. And that's a little weird, but here's the guy who's going to be innervating muscles of the temporal region. Here's the guy who's going to be innervating everybody else. What's going to happen is the contralateral side sends axons to the corticonuclear or cortical bulbar tracts that innervate both of those. So if I want to wrinkle my forehead, smile, grimace, do whatever, these guys are going to be receiving innervation from the cortical bulbar tracts, telling the facial muscles to go do something. But the same side innervates, well, first off, it innervates the one over here, so a little branch is going to the contralateral side and out to the opposite side of the face. But there's a little bit that peels off, and for some reason it goes to the ones going to the forehead. So if I wipe out this tract, I've wiped out the ability of my lower face to move, because this guy just got traumatized. But this guy, going to the temporal region specifically, still has a little bit of innervation. So if you've got a central lesion of the cranial nerve of the tracts leading to 7, you'll have Bell's palsy symptoms, but with forehead sparing. If you've got Bell's palsy, forehead's not spared, the whole side of the face is deinnervated. That's something that gives people trouble sometimes, so hopefully that's been cleared up a bit. Alright, we're going to move on. This is the end of Cranial Nerve 7.